Good morning, good afternoon, and good evening, and welcome to today's PCR webinar on TAVI and concomitant coronary artery disease. My name is Ravi Bindi. I'm an interventional cardiologist from Sydney, Australia, and it's a privilege to have joining me today Dr. Shai Sen from London and Professor Giuseppe Tarantini from University of Padua in Italy. The learning objectives of this session today is to learn when coronary revascularisation is needed in patients undergoing transcatheter aortic valve implantation. Second, to choose the most suitable and appropriate valve for coronary artery disease patients in order to maintain vascular access. Third, to select the best timing for PCI in such patients. Third, to learn strategies and techniques to access coronary arteries after TAVI has been done. And finally, to get an understanding of how interventional physiology can guide PCI in patients undergoing TAVI. We will base our discussions around a real case, an interesting case. Without further ado, I'd like to invite Giuseppe to start the case, and we'll talk through as we proceed. Giuseppe?
Thank you, Ravi, and thank you to PCR for having me for this very interesting webinar. So let's get started for the sake of time and the discussion with the medical history of these patients. So this is a female, 85 years old, some risk factors, and prior history of asymptomatic severe aortic stenosis on clinical follow-up, and was admitted in 2020 for dyspnea, near class 3, and atypical chest pain. Let's see something more about the echo findings. Here you can see that TT, we have a significant aortic stenosis with an aortic valve area that is below 0.8, and the index value is below 0.6. The Vmax is 5.2 meter per second. That means that even in the absence of symptoms, this patient had to be considered for aortic valve replacement. The mean gradient was about 70 millimeter of mercury. Then related to the other valve, we don't have concomitant severe heart valve disease. And related to the chambers, the ejection fraction was about 60%. The aorta was 28 and ascending was 36 millimeter. Let's try to see together now the angiography. This is the right. I actually do not have, that seems to be very clear because actually I don't see any significant disease. And moving to the left, what we can see is a clear diffuse disease. We have to understand if we are talking about a significant diffuse disease or a diffuse disease that has two spot lesion inside. We cannot estimate that, definitely by angio, and there is also a diagonal that has, some kind of disease also at that level. So we have for sure two vessels involved. The right is clear, and let's move to the CT matrix. Here you can see that the average diameter is about 23.5. The area is 424. The perimeter is 74. Related to the cusps, they are calcified, and there is a porcelain aorta. But what is important to share with the audience is the picture in the bottom right of the slide. Severe calcification, but it's not just important the amount of calcium. What is important is the feature and the distribution of the calcium. In this case, you can see that the calcium goes down to the left ventricular outflow tract. That is something that's, make this procedure a little bit more risky. So it's important also to make some discussion related to the valve selection in this case, on top of the fact that we have also a simultaneous coronary disease. So going ahead with the other evaluation of the case. Yes, there is some technical time lag between, one slide and another. Now you can see the circulation view of the aorta with the clear tortuosity of the distal and abdominal aorta and severe calcification at the level of the iliac arteries. But actually, on the left-hand side, you can see the left iliac artery. You can see a tight lesion, but in the right axis, the measures are quite good because all the way are higher than 5.5 millimeters, either say more than 6. So we shouldn't have any problem by a transfemoral approach. Waiting for the next slide. Okay, case summary, 85 years old, severe symptomatic, aortic stenosis because of dyspnea and because the patient was almost asymptomatic for angina, severe to coronary artery disease, and TAVI transfemoral was amenable. The scores of this patient were syntax score 27, but actually we're not talking about 3 vessel disease. This is very important for the discussion. The STS score was 4, that means intermediate risk patient. The frailty was 4. Having said that, I think this is the first crossroad. TAVI plus medical treatment for coronary, TAVI plus PCI for coronary, or SAVR plus CABG. I will hand over to the chair of this session, Ravi.
Thank you very much, Giuseppe. This is a very interesting case. And the first question for us to think about, for you, the audience, to think about is what is the best therapy for this patient? Should this patient undergo TAVI or surgery? And what impact does the presence of coronary artery disease, how does that affect our decision-making process? Shai, this is a typical patient we see in our clinical practice. How would you determine which approach you would use, and how do you integrate the complexity of the coronary disease and the aorto-annular characteristics and the vascular access characteristics to help tailor the right decision for this patient?
Thank you, Ravi, and thank you, Giuseppe, for a fantastic case. I think you have to take all the information with regards to the patient, from the age and the frailty of the patient, which is extremely important, because that will determine the recovery and their course through the procedure itself. I think the femoral access is suitable, as Giuseppe has said. And moving on to the coronaries, it seems to be proximal LAD disease with further diffuse disease in the distal LAD. The timing of intervention there is really the key question of this whole session. My approach to these patients is to treat the predominant lesion. And here we have coronary disease, and further downstream, ultimately, we have the aortic stenosis. And so you can liken this case to a true assessment of tandem lesions, coronary lesions and valvular lesions. She has an aortic gradient that is severe, a peak velocity well over 5 meters per second. And I would approach this by a minimalistic approach to treat the valve first and see what she's left with. It would be nice to get physiology up front so we can learn from the hemodynamics of the left anterior descending artery. But given her age, I would try and avoid, with her frailty, I would try and avoid long-term antiplatelet therapy here, at least until we've assessed the coronaries.
Giuseppe, can I draw you out a bit? Are there any coronary anatomical features that would push you towards surgery in this patient?
This is a very good point, and we know, based on the guidelines of myocardial revascularization, that we have only 3 class 3 indication for PCI, and these are left main with a syntax score higher than 33. We have the case of 3 vessel disease with a syntax score higher than 22. whether, whether or not the patient has diabetes. In case of diabetic patients, when we have three vessel disease and even a symptom score less than 22 may favor surgery. But in this case, what we have is actually a two vessel disease patients. That's, we know by the guidelines, is a kind of, you may choose SAVR or PCI in an equivalent manner. That means what be indication for both cases. And actually, I agree with Shai, that's the point for this, already is to think it's the proximal LED. So actually on, looking at the patients and not at the segment or the lumen or the vessels, etc. Actually, we are dealing about a single vessel disease patient. So in this case, I would prefer to go for, considering the age, the frailty, and, what we have learned in the past, 2 or 3 years from this kind of procedure, I would go in favor of PCI, but the point of Shai was very important for the audience. We don't have to think at the feasibility of the PCI. We have to think at the indication to do the PCI, a simultaneous PCI, because the feasibility is never an indication in these patients, because we need to do what this patient needed to, to stay better and to not harm the patient at the same time.
Excellent. I think that's a really good discussion about integrating the clinical status of this patient, an elderly woman with frailty, combined with the fact that it's feasible to do TAVI. The coronary disease is not overly complex, and we want to keep a simple strategy that doesn't cause harm and gives this patient the best gain. So we all agree that TAVI plus or minus PCI at some stage. So let's move on with the case. Giuseppe?
Yes, please put on the screen. Okay, so whatever is the opinion of the single people, we have to highlight to the attendees that the predominant role stay in the heart team. So the heart team is class 1 indication in the guidelines, and the next year these guidelines will be updated, and this kind of recommendation is even more important, reinforced and highlighted in the fact they need to be upstream. So we don't have to take the decision after the surgical refusal. So the heart team is upstream of all the other decisions and need to involve different people around the table. So having said that, the second point is to try, and I think this is very difficult, to standardize and objectivate the judgments and the final decision of the art team. So what I used to do is to borrow the reports of the ESC guidelines and to look at the 3 different clinical, anatomical, and other condition features that may suggest that it's better to go for TAVI instead of SAVR. And I used to start the art team on top of the report, of this report that I'm going to show to you, that says for this patient that we have 4 points in favor of TAVR for this patient and only 1 point in favor of surgery. So on top of that, I think the art team has to decide what we have to do. And for the discussion, before handing over to Ravi, the only point favoring SAVR is the fact that there is the concomitant coronary artery disease. It's up to you, Ravi, now.
Yeah, thank you, Giuseppe. This is a very important discussion in terms of identifying how do we assess the severity of coronary artery disease. We've said coronary artery disease might sway us in favor of surgery. Giuseppe, I'll put it back to you. How do you assess the severity of coronary artery disease in determining this decision?
Yes, as I told you before, and I think it's important to repeat this concept, when you don't have clear contraindication, okay, in this case, we don't have any contraindication to PCI because it's at the end is a single vessel disease. The point is that we have to go for a full metal jacket. No, first of all, is there a clear ischemia in this vessel on top of the angio pictures? This is the first question. The second question is, Should we go for full metal jacket, or it's enough to treat the proximal lesion, as Shai suggested? Or we have two-spot lesion to fix? And what is the final goal for the audience, and mainly for the patient, is to completely eliminate any potential ischemia or just to reduce it, based also on the result of ischemia. All these points make me, make me decide to go for PCI and TAVI, because this was also the objective findings from the heart team. So if you agree, I can go ahead with my presentation, Ravi, just to highlight with the audience that the final decision was TAVI, as I told you before, and there is another crossroad. It is interesting, which is the TAVI, the THV system, to select for this patient, considering that we have to think at the anatomy, but also to, the coronary aspects. So self-expanding, balloon expandable, or mechanical expandable valve. Ravi.
Thank you, Giuseppe. This is a very important discussion point, because we're balancing two things here. One is we're balancing the optimal delivery of a valve with an optimal valve result, a TAVI valve. And on the other hand, we want to preserve coronary access, which is particularly important if there's coronary disease or the patient has a long life expectancy. Giuseppe, can you talk me through your thought processes in selecting a specific type of TAVI prosthesis in patients in whom coronary access is important?
Okay, I will talk in the meanwhile. The attendees can look at the video, because this part is very standardized. So the only things that I want to say that I used to do for this very simple case, an angio-guided puncture from the right, it takes no more than 5 cc. But, while you're seeing, the procedure, we can discuss also this very, I think the most important aspect of this procedure is to select, the appropriate THV. So my consideration is the following. So in general, even though we have to wait for randomized head-to-head comparisons between different THV valve in this setting, and for sure in the next upcoming years, we will see these results, we have to say that, for sure, a shorter valve that stays below the coronary might be the solution in the vast majority of cases, because you don't have any structure between your catheter and the coronary. But in this case, we had this, the distribution of the calcium was not for me so reassuring. So in this case, we decided to go for a self-expandable valve. And among the self-expandable valve, you can use different type of self-expandable valve. And you can select different type, but we decide to go for a self-expandable valve with a clear open cell design in front of the coronary that permit to engage easily the coronary artery. So you have different options, but among them, for these cases, we decided to select the accurate.
Shai, if I could ask you a question, if you weren't going to use the NeoAccurate and you were going to use an alternative valve, what are the techniques you have to try and preserve coronary access, not only for this particular case, but perhaps in the future if you were doing valve and valve?
So thank you, Ravi. So my experience, I would completely agree that I would go for a self-expanding valve here. The major concern is that left ventricular outflow tract calcification. And in an 85-year-old, you don't want to rupture the aorta or cause any issues. So my experience is largely with the Evolute Pro Medtronic valve. And there are some techniques you can do to preserve coronary access. We've kind of perfected that with our research program over the years. There are other valves like the Portico valve, which have a far more open cell access. And there are techniques using the Medtronic valve that will enable you to essentially align the valve so you can easily access the coronary arteries. And that will involve using the washports, pointing the washport away from you. And then there is a radiopec hat at the top of the valve that you can use to guide the positioning of the valve as you insert it into the position. That will enable quite easy access with guide catheters that I'm sure we'll discuss later on. But I certainly would be looking for a self-expandable valve here.
Okay, so just to summarize this discussion, I think we've all agreed that because of the potential risk of annular rupture or annular rupture in particular with the calcium nodule in the LVOT, we favor a self-expanding valve. Secondly, we acknowledge that an open cell design is obviously going to allow ready access into the future. And if we're not going to use an open cell design valve for whatever reason that we have, then I think trying to be familiar with techniques such as commissural alignment to enable enable ready access is something that's important. So I think these are critical elements, and clearly an understanding of the aortoannular anatomy is important, but also understanding the specific valve design features is critical to this decision. I'll ask Professor Tarantini to move ahead with the presentation now, and we'll see. We'll keep going.
I will go ahead with my presentation. So the point is this: another crossroad to discuss is the following. We have to not forget that we have something also to consider related to the coronary. So is PCI before TAVI? Is PCI plus TAVI in the same setting, or PCI after TAVI? I think this is another very real crossroad to discuss.
Absolutely. Absolutely. I think we know that we have an absence of published data on when, whether to revascularize and when to revascularize. And I suppose we could start the discussion, Shai, by saying what sorts of coronary disease would you revascularize before, or would you always revascularize after?
That's a very good question. I think we're not guided by any evidence. We are, as clinicians, working out are they become hemodynamically unstable during valve placement if we do not treat the coronary disease first. I think there is a subset, the left main subset of patients I would intervene on first. So if it's a ostial left main, body of left main, or distal left main, I would probably intervene because any hemodynamic instability there may make the procedure far more high risk. Again, the complexity of the disease will take some kind of consideration there. If we're thinking about highly calcific disease, as we've got in this case, I would err on the side of caution and probably go for the valve first. So that is my consideration in terms of complexity of the coronary disease. And then it also depends on the valve. So are we pacing and dropping the pressure and therefore dropping perfusion pressure to these coronary arteries? Or are we using a system where we're maintaining pressure throughout? So those are the aspects that come through my mind. But certainly the left main would be somewhere that I would intervene or have a very low threshold to intervene first.
Professor Tarantini, are there any subset of patients in whom you would revascularize before, in addition to the left main? If you were doing rotoblator, is it easier to rotoblade before you put a valve in, or does it not matter?
I fully agree with Shai. The concept, just to simplify a little bit more for the attendees, is the following. When you have a very proximal lesion where you may create some problem also during the expansion of the valve, that is the left main or the proximal LAD or proximal dominance, right or circ. In this case, it's, a 5 minutes procedure. 5 minutes PCI. So you won't risk anything in this case because it's, in this condition, I prefer to do the PCI before TAVI. But when you have the feeling, when you have doubts that the complexity and the duration of a PCI is going to be longer, is going to be higher, in this case, I prefer to do a PCI, complex PCI, on top of a fixed severe stenosis, and not with a background of 100 millimeter of mercury or gradients. So when I think that I have to use rod ablation or to go for 3 to 4 stents with the risk of no reflow, etc., it's better to be sure that we don't have any gradients. In this case, mostly we have a normal ejection fraction. So if we have a normal ejection fraction plus a fixed severe aortic stenosis, you can do whatever you want at this coronary tree because you can take your time, you can breathe and relax. So at the end of the day, the concept is that the complexity of the procedure gets you, preferring to do the TAVI before the PCI. But at that point, going back to the focus of this webinar is which valve may permit to you to do that.
Okay, so if I could just pose a couple of quick questions that are very relevant and very interesting questions from the audience. One is a comment. What's the main purpose of this intervention in this patient? Is it to improve symptoms, quality of life, or longevity? And I guess that also, as you, Giuseppe, have described, is probably the central part of the decision process about revascularization here, I think.
Yes, I can answer to this point very quickly. In general, this procedure in patients older than 85 years old, it's difficult that can prolong the life. So in the vast majority of cases, what you improve is the quality of life. This patient has mainly dyspnea, that is a class 3, that means severe symptoms, and some atypical angina. But actually, I fully agree with the question of the attendee, that is, what we have to look at. So we have to fix for sure, the severe aortic stenosis. That for me is the reason for hospital admission. But we cannot forget that we are doing a complex and costly procedure. So we need to be sure to evaluate first the role of the ischemia in these patients. So it's not just to do and to put some stents. It is just a matter of cerebellum. We need to apply the brain and to say, first of all, is it needed exactly as our friends from the audience asked it to us. So the point is absolutely the indication, not the feasibility of an intervention.
Yeah, and the audience has also asked a very relevant question because revascularization now entails dual antiplatelet therapy. And we've recently seen studies that suggest single antiplatelet therapy post-TAVI is adequate. So I guess exposing someone to dual antiplatelet therapy for a putative reduction in ischemia has to be balanced against the risk of bleeding. Yes. I wondered if Shai, if you have any thoughts on that, because bleeding in this population is quite profound.
Absolutely. She's 85, she's frail. And depending on how you structure your intervention, you could end up with quite a lot of stent, or as we may find out, we go through a more targeted strategy, a wider bore stent, which will allow us probably to reduce the duration of dual antiplatelet therapy, even in this patient. So I think that is something to take into account, particularly the timing of the intervention and then the duration of the antiplatelet.
Excellent. In the interest of time, we might just move on. Sorry, Giuseppe.
Just very, very, very briefly, I think that's just to be even more clear to the audience, my attitude in this case, when we have diffuse, very calcific, non-specific symptoms, is to stay away from tackling this kind of combined procedure. But when we're doing procedure like that, we need to be reasonably sure that we can stay away, without also harming the patient, because we have to be sure that we don't have a huge ischemia, because the goal is to reduce the ischemia. It's not to fix and to create something that is a kind of perfect coronary tree, but it's just to evaluate and to be reasonably sure that we can skip the PCI, or to minimize and to do as simple as possible. This is the main goal.
Excellent. Look, very good points. I think just to summarize, I think most people would, if in the absence of classical symptoms of angina, most people would only treat proximal LAD disease or left main disease before doing a TAVI. And I think assessing the relevance of ischemia or the extent of ischemia is clearly something that our panel think is important. So let's move on with the case, Giuseppe.
Yes. So the other point, we have in part already discussed this point. So PCI first, TAVI first, IFR-guided PCI. We have in part already discussed this point, Ravi. I will hand over you again, but just to say that going with PCI first should not be considered as a wise approach, probably. What do you think, Ravi?
Look, I agree with you, Giuseppe, unless there's a critical left main lesion, which is anatomically very clear. I think I don't think angiographic guided PCI is appropriate. I guess the question, and one of the challenges is, how comfortable are we doing coronary physiology in patients with aortic stenosis, and how reliable is this? And I think we're very lucky to have Shai, who's an expert and has done quite a bit of work in this field. Shai, can you talk us through the role of coronary physiology, the pitfalls, and which indices we should be looking at?
Thank you very much, Ravi. So I think with coronary physiology, the first thing to state in this subset of patients, there is no hard outcome data. It has not been validated in this subset of patients. FAME2, all the defined studies excluded significant aortic valve disease. So we're in an evidence-free zone. We do have small investigator-led studies that have compared hyperemic indices like FFR versus non-hyperemic indices like IFR. And the setting of these studies for the comparison was around the TAVI procedure. So these patients were on the table. They were going to have their TAVI procedure. They often had a temporary wire or the ability to pace through the safari wire. And so we were very comfortable in giving boluses of adenosine and intravenous adenosine. If we go back to the case that we're talking about, this patient has tandem lesions in the coronary artery. In order to assess that with FFR, you would have to induce hyperemia with an intravenous infusion. That in itself can cause bradycardia and hypotension in a patient that has severe borderline critical aortic stenosis. So I can understand some anxiety about using hyperemic indices in this setting. The second point is the physiological basis of hyperemic indices in this setting. And Giuseppe has clearly said that we are dealing with the ultimate tandem lesion here. We've got stenosis in the coronary artery, and we've got the aortic stenosis more distally. If we pass a pressure wire to the distal vessel in this situation, no matter what hyperemia we are trying to induce, it will always be suboptimal because the flow is restricted by the aortic valve, the left ventricular hypertrophy, and the high LV EDP. So there's lots of factors that prevent maximal hyperemia. And at its simplest level, FFR needs maximal hyperemia. And what we've shown in our studies is that when you use resting indices, you obviate that need for hyperemia. And hopefully we'll see some of the findings with this case.
So Shai, just one more aspect that I just want to draw you out on. One of the components of aortic stenosis physiology is LV mass. Is there any point doing physiology before you alleviate the aortic valve gradient, and then which subsequently leads to regression of LV hypertrophy? Is there any point of doing it now, or should we wait for 6 months or 3 months and then repeat these indices later?
So absolutely, yeah. And we've looked at that in a systematic way. So we've taken patients, measured their physiology, FFR, IFR before TAVI, immediately after TAVI, and then 6 months down the line, where they've had left ventricular regression of hypertrophy, and obviously the valve has been released. So what we found is that the hyperemic index significantly changes over that 6 month period of time. So the measurement you get at the time of decision making, which is pre-TAVI, is completely different to what the measurement you get 6 months down the line. With IFR, however, because it doesn't get affected by the downstream effects of the hypertrophy, the EDP, or the aortic stenosis, that value doesn't change 6 months down the line. So what we see is that your value pre-TAVI is indicative of the stenosis itself, the coronary stenosis itself.
Okay, excellent. I think that's really important learning points there. I think we have concluded that resting indices are probably more reliable. They're predictable out to 6 months, and they're quite safe and easy to do. So I think we agree that a resting index such as IFR is useful here. So Giuseppe, let's move on with the case and see what you did and how what ended up happening.
Okay, before going ahead, I just want to say something that while waiting for randomized trial, because there are some ongoing, there is one also that is run from Italy that is named TAVI, etc. So the point is that the message, on top of the complexity and on top of the fact that Shai is a super expert on that, just to simplify the final message is that the IFR value do not change after TAVI. On the contrary, the FFR value decrease after TAVI. So the point is that it seems from these very early studies that going with the IFR seems to be in the acute phase more reliable than the one from FFR. This might be something, if Shai is okay with me, that can be delivered with some kind of confidence. Okay, so our decision process. These are all the different steps. Functional LAD evaluation before TAVI, because we are just focused on LAD. I'm not impressed by the diagonal or Ramus intermedium, etc. These are something that are not so important for these patients. TAVI, I decided in this case to go with accurates, but you can argue it's not mandatory to select accurates. We have already discussed these points. Then we have my goal was to make another evaluation after TAVI, just to confirm that the stability of the physiology measurements are there before getting involved in a very complex PCI that I don't want to do. So this is my feeling from the very early beginning. But let's see if I can stop just, with a feeling to stay away, or we need to do something, and which is the real aim of an additive PCI in this setting. And at the end, that's PCI if needed and functionally guided. So now we have to go to the live, I think, in a box. Let's see if I'm not wrong. Okay. So in this part, what we did is to go with the wire. You can see by the movement of the wire the difficulties to go across the very tight, the very calcific lesions, because this wire sometimes is not slippery like other wire, hydrophilic wire that we use every day in the lab. So you need to be a little bit more patient, but at the end it is possible to get through all the way in the vessel. And you need to do some maneuver that is clockwise and counterclockwise rotation, just to avoid to push and to degenerate and to create some problem in the wire. As I told you, because we have already a tandem lesion effect by the aortic stenosis, we need to be sure to stay all the way in the vessel and not to stay in the mid portion of the LAD when we want to do a functional evaluation. So our decision in my center is we use both IFR and FFR because we have the systems that permit that. But as you can see, by this case, I was able to go across all the lesion. This is the physiology measurement. We started from IFR first, but because in this case, for me, it's more consistent with the real ischemia in the setting of having also an aortic stenosis. And here it is clear that we have a very significant IFR. So we cannot say, this is not negligible. Okay, so we cannot pretend that we don't see this value. Okay, so the point is that, and this is another point in favor of resting index, is to spot where is the location and where is the lesion that is mainly responsible for this reduction in coronary flow reserve. And accordingly, we decided to do a scouting and IFR scouting, there is a gentle pullback, and there is a first step in the distal portion. Then we have a kind of plateau that is, reassuring that we don't have a very severe lung disease. And there is, if you look also at the simultaneous angio and the position of the wire, a second step that is proximal. This step is very important also. So now, by means of the scouting, what we can do is to properly evaluate. Okay, next slide. I will move forward. The two steps. And here you can see that we have a first bump that is 0.17 and a major bump that is 0.20 that is in the proximal part. And I like that, to be honest, because I cheer for this kind of the result. And it was for me reassuring that I don't have to treat all the vessel with a full metal jacket, because, I would have been disappointed by, a result of a diffuse disease along the way of this coronary. So I was a little bit reassured by the fact that I might, by fixing the proximal part, I can finish up with a final IFR that is 0.883. It is not too bad at all, because it's very close to the threshold of 0.86. I don't know, Ravi, if you want to, involve Shai for this discussion, or what you think also about this, if it is well balanced for you or not. Or if it is too conservative. If it is too conservative for you. This is not for me, but,
Look, we've got about just under 20 minutes to go. So I think, but this is a really important point here, in that the traditional teaching with physiology is to try and render the vessel ischemia-free. But you've got to balance that with the length of the lesion you're treating, the diffuseness of the disease, versus the biggest bang for buck. And I think, Shai, how would you approach this? I mean, would you try and render this vessel ischemia-free based on that scout, or do you think you've got to be pragmatic in this 85-year-old lady?
So I would be pragmatic. This is a very elegant use of the IFR scout technology, and it's giving you data that you should use clinically. I think targeting that proximal lesion will reduce her risk, there is no doubt. And I think we've got to think about a spectrum of risk. So an IFR of 1, fantastic, you'll probably be fine. An IFR of 0.63, your risk from the coronary disease is high. The higher you get it, you are doing benefit for that patient. So I would not go for perfection here. I would accept 0.83, put a short, wide stent in, minimize the duration of antiplatelets.
Okay, very sensible and pragmatic advice there, Shai. I think we've got to be pragmatic. So, Professor Tarantini, what did you do in this situation? I presume you went ahead and did your TAVI implantation now?
Yes. You wanted me to go ahead with my presentation, the movie?
Yeah. Let's move on with
discuss, during. Okay. Okay, here you can see that we went first, as Ravi said, for TAVI. Okay. It's a quite standard part of the procedure. This is an AL2. We used to tilt up the tip of the catheter just to be sure that we can place the wire, the stiff wire, and to be sure to stay away from the cord there. Here you can see the wire. As we can discuss these points. We went for a balloon inflation. It's a 20-millimeter balloon. As you can see, it's quite stable. There is no movement of the balloon. And we made also an injection to be sure that we don't have any impairment of coronary flow. And at the same time, there was no leakage. So we were pretty sure that we can go ahead with the final 25-millimeter valve of accurate. At that point, please, Ravi, you can interrupt me whenever you want.
So Giuseppe, the theme here is unrevascularized coronary arteries. How comfortable are you pre-dilating a few runs of fast, rapid pacing in someone with unrevascularized proximal LAD, plus the risk of aortic regurgitation? What Are you comfortable, uncomfortable? You think about it?
Now, this is a very good point because mainly this point is raised when you select a balloon expandable valve. This is one of the arguments in favor of self-expandable. Actually, also in self-expandable, you have to predilate or post-dilate. So the point is that you cannot get rid completely from the need for overpacing. Actually, if you are well trained, we have to share with all the people in the audience, etc. It takes 10 seconds. So you don't need more, because this is not a standalone valvuloplasty where you want to finish up with a perfect gradient. You have just to create the way and to guarantee an expansion of the valve, and to avoid, when you retrieve the catheter, to have a pop-up of the valve. So this is the rationale. So you need to be very gentle and very quick. So this is a very good point, and thank you, because give me the opportunity to clarify these points. So as you can see, we trying, because there is a lot of calcification of the aorta. It was even difficult to get down with the pigtail. And you need to be sure to stay in the right position, because my suggestion for this valve is to stay at the hinge point of the coronary sinus, because you have to orientate the ring of the valve, of the crimped valve, at that point, at the level, to avoid to have surprise when you deliver with the knob number 2, with the knob number 2, when you have the full valve deployment. So the loading of the valve is quite simple. You have a loader. Here it is clear. You go in with the loader, not all the way in with the loader. This is important as a recommendation. Otherwise, it might be tricky, to go through with the valve. So it's just halfway in, and then you remove the loader. At that point, you have to push in. This is not too difficult, even though we have a very tortuous and calcific aorta. At that point, so you get through the arch. You don't have to change, for me, at the very early beginning of the experience, we try to change, the projection. But I think when everything is smooth, you have to give a look just at the tip of the wire, because this is the only very risk point to avoid to perforate. At that point, you go in your orthogonal view. You visualize the ring that has to stay at the hinge point of the coronary cusps. When we're fine, another suggestion is to push the wire to be sure that you don't have the wire floating in the ventricle, and to touch the apex, just to have a kind of stabilization of all the system. You make an angio in this case, because we want to be very didactic also, for this webinar. And then you go halfway with the knob number 1, very slowly, just to open up the crown a little. There is not a full deployment of the stabilization arch. When you're pretty sure, you go all the way down with the knob for the full opening of the stabilization arch. It is important to reduce the parallaxis of the valve. It's not always feasible, but this is the role also the predilatation, because when you create the way, it is possible you permit to the stabilization arch to work a little bit better. At the end, you will finish up by delivering with the knob number 2, the stent, the frame of the valve. At that point, this is a very delicate point, because you have to disconnect the system with the valve. Otherwise, you might have a pop-up. You have to play with a wire to push forth and back, just to be sure to go into the frame without, grabbing in any points the frame of the valve. Otherwise, you might risk a pop-up. I used to go slow, because you need to take your time. Slow means 10 seconds more. I know that the time is important, but sometimes it's even more important to breathe and relax, as I used to say also to the people that work with me. When you stay in the descending aorta, everything is the system has to be relaxed. Please, Ravi.
So Giuseppe, there's a question from the audience, just a technical question, because you very elegantly demonstrated passing the sheath into the iliac, which is very tortuous. The question was, did you have this sheath go over the wire, that's stiff wire in the LV, or did you have a dedicated stiff wire to deliver the sheath and then you crossed the valve?
Now, actually, I can tell you one thing that seems to be counterintuitive, but the stiffer is the wire. If we use a wire that is too stiff, you might have more problem in this case. So in my experience, it's better to go with the Safari or an Amplus wire, etc., and to avoid super stiff wire. This is my personal recommendation, because you have a lot of friction, the level of calcification, and sometimes you don't have the possibility to play by pushing and relaxing the system to detach the valve from the aortic wall. So for me, you need to use the right, not too stiff wire. At that point, we delivered the valve, everything was okay. We repeated the physiology, shy, and as you can see, we had the same result. This is impressive, and probably you have to comment on that. It's impressive, the reproducibility of the measurements that you do in this challenging situation. Before, and at that point we have to decide to do something. As you can see, the LED is not reassuring, also by angio with the wire in, because it seems to be 90% with the wire in. I don't know if there is a kind of functional constriction, also a little spasm, but I didn't like this situation. And then we have also the proof of concept that there is an ischemia, and this is the lesion where the coronary flow reserve is highly reduced. So at that point, we decided to fix only the proximal lesion. And based on the comment of Ravi that he did before, we selected also a stent that had a C mark for 1 month of dual antiplatelet therapy, because the patient is 85 years old. This is not a major criteria, 85 years old, to adjudicate high bleeding risk, but it's one of the 2 minor criteria to adjudicate the high bleeding risk. So on my side, we decided to go very short, very simple procedure, pre-dilatation, and then we place a stent. And at that point, we were pretty, satisfied by the fact that, the patients, in this case, the patient is not intubated. We don't have transesophageal echo. We don't have even anesthesia, because what we used to do is exactly like the PCI in the University of Padua. So the patient is, used to talk also with us during the procedure. Sometimes we go with fentanyl, just 1 cc that is diluted, just to avoid, a little bit the sensitivity of the patient, and that's it. Okay, the final results, angiographic results was, if we can skip this part, we can go to the final results. Please, to the Regia, if it is possible, to go to the final results, to the end of the...
Giuseppe, whilst they do that, can I ask you what decision-making you have with regards to your guide catheter, and what guide catheters you use post-TAVI?
Thank you. Thank you. This is a very important point. For all the attendees, my suggestion, and I believe is also the suggestion of the chairman of this session and Shai, is to use, to be as simple as possible. That means that, but you have to know at least one rule. The engagement of the coronary in the setting of TAVI, the process and the path is top down. Is not tilting up a catheter like we do, currently in the, the vast majority of PCI like XB. So I used to, in my practice, in 90% of cases, I'm able to, sort out any situation with the Judkins. It is 3.5 for the left and 5 for the right. But please keep in mind, don't try to go as a first attempt with catheter and need to be tilted up, because you don't have the room to tilt up the catheter. That is the point, and you risk to harm and jeopardize, the catheter. And this, you have to keep in mind this point, at least on my side.
Yeah. Look, there's a couple of very important messages that have been learned in this last sequence of discussions. The first is the very impressive, I think Giuseppe very impressively demonstrated the IFR before and after alleviation of the gradient was unchanged. I mean, that's a really important message. And Shai, in his study, has showed that after 6 months, the IFR remains unchanged. But if you did FFR, that would change. The second important point is that this is an open cell design, the NeoAccurate, and so accessing the coronaries is easier. But if you're going to use an alternative stent valve platform, having an understanding of how to access the coronaries is really critical. And this isn't like native coronaries where you go bottom up. Here you go top down and you use simple guide catheters. So you don't go for your extra backup catheters, you use your Judkins catheters, and you can use telescopic extensions if you need stability. So this is really, really important. Patients that we treat with TAVI don't come back necessarily to our centers. They may go to another center where the operators have no experience with TAVI. And so we really need to be teaching this message about how to access coronaries in these patients. So let's keep going, Giuseppe, with the case. Any other messages that we've got from this?
Yes, I think another simple message is that you don't have to believe that femoral artery is mandated to engage the coronary artery. The only thing is to select the appropriate strategy and the appropriate catheter that in the vast majority of cases like the one that you use for diagnostic procedure. So it's you don't have to think it's you have to not think it's very complex at the classical complex PCI. And as I used to say to all the people that work with me, you don't need to have a CTO factor to get to engage, a coronary artery and to perform a balloon pre-dilatation and the stent in this setting. So let's see the results. So exactly the same. We foresaw that before putting a stent that we had to finish up with 0.83, and 0.83 is for me very reassuring because I've reduced, for me, remarkably, the extent of ischemia. So probably, Shai, you could comment on that, if I'm supposed by Ravi.
It goes back to the spectrum of ischemia and your spectrum of risk. The lower your IFR value, the higher risk you are for a MACE event. Generally, it will be unplanned revascularization. The higher we get that up, what we've learned from all the FFR studies, the higher your post-PCI value, the lower your risk is. Now, in clinical medicine, there is no point going for perfection in an 85-year-old who has quite diffuse disease distally. I think here you've got an excellent outcome. You've reduced her risk from a coronary perspective, and you've also reduced mortality from a valve perspective. So this is exactly what I would have done.
So Shai, while you're talking on this topic, can I draw you out on the ischemia trial? This patient obviously wouldn't have been enrolled in the ischemia trial because they had severe aortic stenosis, but Giuseppe got a wonderful result with his TAVI procedure. If you were then would it be reasonable to do nothing and just to manage this patient medically, or does the IFR value give you justification to treat the patient?
So there are two conflicting areas or spheres of evidence. With ischemia, again, as you said, this patient wouldn't be included in the study. But what ischemia does tell us is that if we didn't decide to intervene on this occasion at the time of the valve insertion, the patient would probably be safe. We could bring them back to the outpatient office, review their symptoms, and make a decision at that point. So I think you're on safe grounds from that perspective. What we know from the longer-term data from FAME and FAME2 is that the lower your physiological assessment value, the higher your incidence of events. So I think we're in a gray zone, but on balance, I would have intervened.
Okay, excellent. That's really, really important learning messages. Giuseppe, we've had a couple of questions asking about your opinion about the MANTA closure device, which you're demonstrating here, versus using ProGlide plus Angio-Seal.
The time is running late, so we have 30 seconds. I'll be very quick in my answer. So the main contraindication are severe calcification and a reference vessel that is below 6. So the point is that when you have a large tortuosity, calcified vessel with a reference vessel that is below 6, and you go with the 18 French compatible manta, it's better to skip to other device. But when you stay in the range of the indication, this is the only device that has a C mark for closing an all of 24 French. So in my experience, the results are excellent.
Excellent. Look, that's a wonderful, wonderful summary. Do any of the panelists have any final comment about the topic of concomitant coronary artery disease and TAVI before we close this session?
I think it's an excellent demonstration. I think this question will be increasingly posed as we start to do TAVI in lower risk patients and younger patients, especially as 50% of our TAVI population have concomitant coronary disease. So I think it's a very timely presentation.
For me, my comment is related to the perspective, because I think that the technology is to make 2 steps forward. The first one is to create some valves that respect the anatomic location of the coronary. So we need to have something that permit to orientate the first valve. But actually, even more important and of concern actually is when we think of the TAVR, and I would like to remind to all the people in the audience that in 2 years from now, we will have more than 10 years, 12 years of follow-up, and we will start thinking how to face this new field that we are largely unprepared.
Excellent. Look, thank you very much. And look, I think you'd all agree that this has been a wonderful session. I think during this session, we've learned about coronary revascularization when it's needed in patients undergoing TAVI. We've discussed factors that we need to consider to pick the right valve for patients to preserve coronary access. We've also discussed issues affecting the timing of when to intervene the coronary arteries in patients undergoing TAVI. We've had a good discussion about the importance of simple techniques and strategies to re-access coronary arteries in patients who have undergone transcatheter aortic valve implantation. And finally, we've had some really wonderful insights by experts on how interventional physiology can guide PCI in TAVI patients. So thank you all for your attention and participation in today's webinar.